Let me just give a short introduction.
Okay.
Welcome to everyone who's joining in on Zoom as well as live on YouTube. This is a webinar series that I've sort of picked up. This is Breast Care Insights. I'm Dr. Theekshana, Pathirana. I'm a surgical oncologist from Sri Lanka. It's an area that has been discussed in the realm of breast cancer surgery for many years. How to de-escalate axillary management, and I thought of inviting someone who is quite suitable to discuss this topic, especially in the UK. There won't be any conference or discussion that he's not been included when it comes to talk about this topic. Mr. Amit Goyal, he's a consultant endoplastic breast surgeon and associate professor working for the University Hospital Royal Derby and Burton. He has been there for more than 15 years. He's been a part of the Cardiff University as lecturer in his early career. And he has been a pioneer in the management of axilla, starting off with the UK Almanac trial. I think he's one of the few surviving investigators from that trial. And he is also the chief investigator for the UK postdoc at NEC, and I think NodeSmart trials as well, which he'll go through, which are groundbreaking and sort of landmark trials, especially in the realm of axillary management. So this discussion will be valuable for, I think, because my background is in Sri Lanka, there'll be a lot of Sri Lankan colleagues, as well as on YouTube there are a few and a lot of Asian and out of Asia enthusiasts who are involved with breast cancer and breast management. So welcome all of you. And I would like to invite one of my trainers from the UK and a well-known consultant in oncoplastic breast surgeon, Mr. Amit Goyal, to take off the topic de-escalation and axillary management of breast cancer, evidence to practice. Over to you.
Thank you, Theekshana. Can you hear me clearly?
Yes, loud and clear.
Okay. Can you see the full screen slides now?
We can. And just to add, if you have any questions, please do pop in the chat function, as well as on YouTube. You can pop in your question as well. Yes, Mr. Goyal.
I can't see the chat function, so just interrupt me if there are any questions.
I think at the end of your presentation, we'll take up the questions.
Okay, thanks a lot. Thanks a lot for inviting and for the opportunity. And so I'll take you through the axillary management as I understand it in the current day and time. It's a very controversial field, especially in breast surgery. So in every conference you attend or go to, there's always a controversy about axillary management. And this is not a new thing. It has been going on for many years. And I also anticipate that in the coming years, this will only carry on. So I don't think we've resolved it yet. So as the new studies come in, the management is going to change. So let's start. So my personal journey, like Theekshana very kindly mentioned, started with the first trial, that's the Almanac trial. And then we trained the surgeons in the UK as a part of the New Start training program, how to perform sentinel lymph node biopsy. And then I started the international post-NOC trial, then the ATNAC trial, which is looking at axillary management following neoadjuvant chemotherapy in node-positive patients. And the most recent study that we started last year is the NodeSmart study, to look at patients who are node-positive to start with, but are not having neoadjuvant chemotherapy. Can we avoid axillary lymph node clearance in them? So from a de-escalation of axillary surgery point of view, why do we need to de-escalate, or why do we even discuss it? If axillary lymph node dissection, I always say, if it didn't have the problems it results in, for example, the arm morbidity, complications, then we would never be discussing this. So if it was a procedure with very minimal or no complications, then we wouldn't be even considering de-escalating axillary lymph node dissection. So the problem at the moment is that axillary lymph node dissection leaves our patients with complications that can be long-term. Some of them, like lymphedema, they don't have a cure. They can be controlled with various methods, but they don't have a cure. And more recently, the whole concept, I think, we have tried to question it. And I think in the future, we'll see more and more, that's my feeling, that lymph nodes with immunotherapy coming in for breast cancer, I think the whole aim for de-escalation or preserving the lymph glands will actually change, not just for minimizing morbidity or complications to the patient, but actually to improve the effectiveness of immunotherapy. So I think my feeling is that in the coming years, and I'm myself thinking about maybe starting a few studies on this, that the lymph glands are a part of the immune system of the body. And with the new immunotherapy drugs that are being used, especially for triple negative breast cancer patients, preserving the lymph glands, this is a hypothesis, this is not proven yet, but I think this will be looked at, and I personally am planning to look at this to design studies that preserving the lymph glands in patients, especially like triple negative breast cancer, where you're giving immunotherapy, I think theoretically they may have a better chance, better prognosis, because the immunotherapy drugs will probably work better in them if you preserve the lymph glands, take out the lymph glands. So I think the whole concept will change most likely in the future. So from a historical perspective, one thing I find very interesting is that, we all started with Halsted taking out all the axillary lymph nodes. So we knew that that persisted. But then we did the NSABP, the American study, the B04 study. Now, this was done in the 1970s. So that's many, many years ago, before our times. Now, in that study, patients were randomized into radical mastectomy. That means mastectomy and taking all the lymph glands out for the younger generation. Just a simple mastectomy, that's a total mastectomy. And then the third arm in this study was patients having a mastectomy with radiation to your lymph glands. Now, what was interesting in this study is that there was no difference in survival, even at 25 years. And so this study, the question is, if you had a 25 years follow-up in this study and showed that either taking them out or giving radiation didn't improve survival over and above patients who didn't have anything to the lymph glands, the question is, why didn't we change? We had the data that time, so we could have de-escalated at the very start. So we could have stopped doing that. So in those days, we didn't have the adjuvant treatment or the drug treatment we have today. So in those days, I think the status quo retained because it was still thought, although it did not improve survival based on this study, that it was important for local control. Maybe it was prognostic. You didn't have the molecular tests you have these days, for example, MammaPrint, Oncotype, and other tests you may use in your country. And it informed the adjuvant therapy decisions in those days, unlike today, where more and more adjuvant therapy decisions are being based on, for example, the receptor types and these molecular tests. But this was established that it's a morbid procedure, but it carried on. So then the central lymph node concept came in the 1990s. And we did it was not a new concept. It was given in penile cancer, but it got lost in history somewhere. And it was reinvented, I would say, for breast cancer back in the 1990s. So central lymph node, what's the concept? So the concept is that for breast cancer, it's the first lymph gland receiving direct lymphatic drainage from the primary tumor. And so this concept, based on this concept, you can safely say that if your central lymph node that you've taken out doesn't have cancer, then there is no further cancer in the remaining lymph glands. So you don't need to remove them or treat them with radiotherapy, theoretically. And if there is cancer in the central lymph node, then you can say that there could be some cancer in the higher lymph glands or not. So you may want to treat the remaining lymph glands. But this concept is not 100%, and that's what I would like to highlight here. So even in the studies that we did, which I'll go through, there's a false negative rate. What does that mean? If I take a sentinel lymph node out, the chance that the sentinel lymph node is clear, but there is cancer in the higher lymph gland. So I've missed the correct lymph gland. So that's a false negative sentinel lymph node. So that can happen in around 10% of patients. So these are just some pictures of sentinel lymph nodes. You can use various traces. We'll go through that in a moment. So we did the initial studies, the American study, the B32, and in the UK. So I did the Almanac study when I was back in Cardiff. So what we did was patients who were sentinel lymph node negative, we didn't do any further surgery, and they were randomized to lymph node dissection or sentinel lymph node biopsy alone. And we established, as you can see, the false negative rate. In the Almanac study was 6.7%. In the American NSABP32 study, it was 9.8%. So based on these studies, and when we published the Almanac results, we changed the whole treatment for breast cancer. So in the Almanac trial, we showed that the quality of life is superior in these women who don't have a lymph node dissection and just have a sentinel lymph node biopsy, and associated things like arm swelling, sensory loss, hospital stay, as we would expect. So these studies established that sentinel lymph node biopsy, instead of a lymph node clearance, should be done in these patients. And if there is no disease in the sentinel lymph nodes, you don't need to do anything else. The question was then in the UK that how do you train people? Because all the units till then, if they were not participating in the Almanac trial, they were still performing lymph node clearance or something which is very unique to the UK and some countries called 4-node sampling. So Americans don't understand that. So 4-node sampling, if you're not familiar in your country, is basically randomly, there seems to be some logic to it that you take 4 lymph nodes out, sampling. So it's mainly by palpation. But it's not an American concept. So whenever I talk to them, they say, we have never heard of this. In the UK, it is still done, I'm afraid. So we set up a new start training program to train consultants at the time. All of them were supervised. They were required to do a certain number of cases before they were certified to perform sentinel lymph node biopsy. And they were set the measures that they have to have a false negative rate of 10% or less and a sentinel lymph node identification rate of 90% or more. Now, after having established, so this is back in 90s and 2000s, that sentinel lymph node biopsy, there was no controversy there. For node negative patients, if the sentinel lymph node is clear, you don't need to do anything else. So then we took the concept a step further. Till then, if your sentinel lymph node was positive, then patients still had a second operation in most centers. So they went back and the surgeon performed a completion lymph node clearance. So took out all the remaining lymph glands. So we started thinking, now, can we do something differently for these patients? Because not all of them, when you went back and did a completion clearance, had more positive lymph glands. Some of them only had, for example, no positive lymph glands, but they only had the positive sentinel lymph node, or some of them may have only one more positive lymph gland. So can we actually manage these patients differently based on the tumor burden? So almost like adapting your strategy to the tumor burden in the axilla. So then, and why we could think that? Because we had improvements in systemic treatment, drug treatment, improvement in radiation, and we also had oncotype, mammoprint, and other things that had cropped up. So our reliance on the total number of lymph nodes with cancer became less and less from oncology point of view to decide adjuvant treatment. So the first logical step would be, how do we define tumor burden in the axilla? And the first thing that was used was the size of metastasis in the sentinel lymph node. So if it's more than 2 millimeters, if you see on my right-hand side, So that's a macrometastasis. And anything less than that was defined as micrometastasis. I will not go into isolated tumor cells at the moment. So what about if we start with micrometastasis? Do we still need to clear the axilla for these patients? So we had the two studies, the IBC-SG, the European study, which was the largest study, and then you have the smaller study. So I'll not go into the smaller study. In the larger study, patients with micrometastasis were randomized to having lymph node clearance or no lymph node clearance. And they didn't have any radiotherapy to the armpit in the sentinel lymph node biopsy alone arm. And this trial showed, along with the smaller study, that the results were the same. If you look at the sentinel lymph node biopsy alone arm and the lymph node dissection arm, the results were the same. For axillary recurrence or for survival, there was no significant difference, and for disease-free survival. So based on this, you could say very confidently that patients who have micrometastasis in your sentinel lymph nodes, you don't need to do anything else to the remaining lymph glands. You don't need to dissect them out. You don't need to give them radiotherapy. Now, just to put this into perspective, that both these studies, the largest study and the smallest study, they had very few mastectomy patients, so less than 10%. So there was a word of caution in those days that maybe, I think, for mastectomy patients, we should just be careful because these studies did not include many mastectomy patients. So then what do we do next? So having answered the question for micrometastasis, it was logical for researchers to proceed with the question, can we do something differently for macrometastasis? That is, as I mentioned previously, where the size of the metastasis is more than 2 millimeters. Now, there were two studies back in 2010s that were set up. The Z11 study, that's the American study, that looked at patients having breast-conserving surgery and who had 1 or 2 positive lymph nodes, whether we need to do lymph node clearance or not. And the AMAROS study that looked at patients with 1 or 2 positive nodes, whether we can replace lymph node clearance with radiotherapy to the axilla. Now, both these studies had some limitations and problems because not all the patients included had macrometastasis. And we'll go through that in a moment. So AMAROS study, the question they were asking is, can you replace lymph node dissection with radiotherapy to the axilla? And they were not confined to macrometastasis, and that's one thing which many people forget. They also included micrometastasis, and the tumors were very small. Initially, when the study was designed, they were limited to up to 3 centimeters in size in the inclusion criteria. It was only later on in the study, when the study was not recruiting, they slightly relaxed the criteria. So if you look on this slide here, if you look at 82% or 80% of the tumors were only up to 2 centimeters in size, and very few patients had tumors more than that. And again, majority of the patients had breast-conserving surgery. And if you look at the number of involved nodes, again, this is a very good or low-risk patient. So almost 78 or 75% patients only had 1 positive node. And the interesting thing is the macrometastasis. So only around 60% patients had macrometastasis. Otherwise, 40% had either micro or isolated tumor cells. And we know from the previous study that we discussed, the European 2301, that micrometastasis, you don't need to do a lymph node clearance anyway. So the study's AMAROS study got a bit diluted because of that. And this study showed that if you compare lymph node dissection with radiotherapy arm, there's no difference. For some reason, the second primary cancers were much more in the radiotherapy arm, a fact that has not been discussed many times. It's almost omitted. They were never able to explain that, why this happened. But this is something that you should keep at the back of your mind. And one reason why radiotherapy is being advocated instead of lymph node dissection after AMAROS study is, if you look at the lymphedema rates, so almost half in the radiotherapy arm compared to the clearance arm. Now, some may argue, I think from our own practice as well, that actually you may not see lymphedema as high as you see here in the AMAROS study, in the lymph node dissection arm. And I think I would agree with you. So I personally have not seen a 25% risk of lymphedema in the lymph node dissection arm. So you would question how the lymph node dissection was done by the European centers. We don't see that. So whether the results are still applicable if you do a lymph node clearance properly or meticulously, the question remains unanswered. Interestingly, the quality of life and shoulder mobility, if you look at that, there was no difference in the two arms. So based on the AMROS study, just to summarize, the take-home message is that you could consider radiotherapy to the axilla, and if you are to believe that study, that it causes half the risk of lymphedema compared to lymph node dissection. So you could consider that for T1, T2 tumors. Just be careful if you're moving above 3 centimeter tumors, because very few patients were included in AMROS. But you could consider that instead of a lymph node dissection at your center. And then the reason I've included the Senomac study here with the AMROS study is to actually just dot the I's and cross the T's for radiotherapy. The Senomac study was published in the last 1 or 2 years, 2024. A bit of a controversial study. It didn't do what they said they did. So they had patients with 1 or 2 macrometastases who were having breast-conserving surgery or mastectomy, T1 to T3 tumors, and they randomized the patients according to them to lymph node clearance or no lymph node clearance. So they were trying to see whether you need to do a lymph node clearance or not. The problem in the study, which is it doesn't come out very well, is that they gave radiotherapy to the axilla to all the patients anyway. So basically all these patients with 1 or 2 macrometastases, they had radiotherapy to the axilla, and then they were randomized to lymph node clearance or no lymph node clearance. That doesn't make sense to me, because in the UK, and I think many countries, you wouldn't give both to the axilla. So if your oncologist is giving radiotherapy to the axilla, you wouldn't clear the axilla as well. So that didn't make sense. And this fact was not flagged up in the paper very clearly. So it's basically like AMROS study. You're giving radiotherapy to the axilla anyway, and then you're randomizing, which doesn't make sense. The only thing, a take-home message from this study is that they included a significant number of mastectomy patients. So if you see here, around 35, 36% mastectomy patients were included. So you could say that combining AMROS study and Senomac study, maybe you can consider radiotherapy to the axilla in a patient with macrometastasis, 1 or 2 macrometastasis, in a mastectomy patient safely as well. That's all you could conclude from this study. Nothing else. And the study, not surprisingly, didn't show any difference, because you wouldn't expect to, because you're giving radiotherapy to everyone anyway. So I'll skip that. So this is just the finding that I summarized previously, that the only take-home message for me is that the number of mastectomy patients that was small in AMROS study, it was 35 to 36% in Senomac study. So you say that radiotherapy is an appropriate alternative to consider instead of a lymph node dissection in these patients. So then we come to, okay, so till now we have established that for micrometastasis, you don't need to do anything else to the axilla. For macrometastasis, based on Senomac and AMROS study, you can probably consider radiotherapy as a replacement for lymph node dissection. So then the logical third step would be, actually, do we need to do anything else at all? Can we not do anything? Don't give radiotherapy to the axilla. Don't do a lymph node dissection for these patients with 1 or 2 macrometastasis. So that was the Z11 study that started by doing that, or they intended to do that, but it never happened. So it randomized patients who were having breast-conserving surgery to lymph node clearance or no lymph node clearance. So I've just highlighted in that box a few key points. Although it's a practice-changing, or I would say thought-changing study, which then led to other studies like POSNOC and other studies. So it changed our way of thinking. because till then, we always kept thinking that if you have a macrometastasis, you need to do something to the axilla. So it's definitely a practice-changing study, but I don't think the evidence that came out from it was enough to change practice, but it definitely led to other studies or confirmatory studies like POSNOC. The problems with this study, or the limitations, I would say, that half the patients had macrometastasis, but other half had either micrometastasis or isolated tumor cells. So that didn't make sense because the European study had already shown that we don't need to do anything for micrometastasis. And again, the radiotherapy issues, that half the patients or more than that, they had radiotherapy issues. What I mean by that is that if they were randomized to a no lymph node dissection arm, they still had some sort of a radiotherapy to the armpit. And we know from the AMROS study and the Sanamax study that if you give radiotherapy to the axilla instead of a lymph node dissection, then it's non-inferior to that. And there were issues with follow-up as well. And the study never completed its recruitment, probably because it was a thought-provoking and thought-changing study. But the 10-year results published from this study showed there was no difference in patients who had lymph node clearance versus who didn't have lymph node clearance. But it did not change the practice in our country, in the UK. And if you look at I definitely know for India, when I visited there, it didn't change practice back in India as well. So that led us to establish the POSNOC study. So as a confirmatory study to address the limitations of Z11 study. And what we did was we randomized patients with 1 or 2 macrometastases. We didn't allow any micrometastasis. So it was a purist study, I would say. We allowed extranodal invasion. We allowed mastectomy patients. And you have to remember, Z11 did not include mastectomy patients. And we randomized patients to axillary treatment or no axillary treatment. So if they were randomized to axillary treatment arm, they could have either lymph node clearance or radiotherapy to the axilla, not both. If they were randomized to systemic therapy alone arm, there was no treatment given to the axilla. So no radiotherapy to the axilla, no lymph node dissection. And we have around a median of 8 years follow-up. The results will be ready in July, so in a few months' time. And we are hoping to present it end of this year and publish it end of this year as well. So this will be a confirmatory study that will address all these questions. Now, the next step is, the next question which came to my mind is, fine, but what about these patients who are not having neoadjuvant chemotherapy? I don't know in Sri Lanka whether you do ultrasound scan at presentation, but in the UK, all these patients seem to have an ultrasound scan at presentation. And so if they have a FNA or a cord biopsy proven lymph node metastasis, I'm afraid they move to lymph node clearance at the moment. So the question was, the ultrasound scan and the radiologists are getting better. So just because a patient has 1 or 2 abnormal nodes on the ultrasound scan, should we be doing a lymph node clearance? I mean, one would argue that, fine, these patients have more tumor burden, so they're more likely to have more than 2 macrometastases when you do a lymph node clearance. So they wouldn't fit the criteria for either POSNOC, Z11, or AMROS. So we should. But then to address this, what we did was, we did our own, it was a regional study that we published many years ago, almost 10 years ago. So what we showed is that, yes, overall, the tumor burden is more in these patients compared to the sentinel lymph node positive patients. But if you look at the bottom line here, so these are patients with 1 or 2 macrometastases after a completion clearance in total. So 40% of patients, if you see, still only have 1 or 2 positive nodes. So we are over-treating these patients. So by AMROS, we could have probably given radiotherapy to the axilla if we had done a sentinel lymph node biopsy and decreased the risk of lymphedema. And if you believe when the POSNOC publishes later this year, these patients could potentially avoid any axillary treatment if POSNOC was to show that no axillary treatment is required. But the challenge is, how do you identify these 40% of patients? from the 60, the remaining 60% will have high burden disease. So then we designed our next study. But before that, I'll just show you. So our data is very compatible with data that was published after us by Sloan Kettering. And that showed as well that 43% of patients who had a positive node at the very start on ultrasound scan actually only have 1 or 2 positive nodes on lymph node dissection. And we counted the number of abnormal nodes on ultrasound scan then. Could that predict the tumor burden in the axilla? And the answer was yes. So patients with 1 or 2 abnormal nodes, what we found is that their tumor burden in the axilla is less. So if you restrict yourself to T1 or T2 tumors, and this is a meta-analysis that was published a few years ago that showed that, again, the predictive value, the sensitivity and specificity for 1 abnormal node on ultrasound scan. So it showed that it can predict the tumor burden. So, and that's the whole basis that for NodeSmart that we set up last year. That if you have a patient with a T1, T2 tumor and only 1 or 2 abnormal nodes, rather than doing a lymph node clearance, you could do a sentinel lymph biopsy and take the marked node out as well. What do you mean by that? So that's a concept called targeted axillary dissection that is being used in the post-neoadjuvant setting. So there you mark the abnormal node that has cancer. You can use any technique that you prefer. We at Derby, we use black dye. So in Sri Lanka, you could use the technique that is available there for you. A black dye is very cheap. So if it's there, you could use that. And you could use a simple clip as well. So you do a sentinel lymph node biopsy and take the marked node out as well. So that's called targeted X-ray dissection. If you're planning to use the black dye at your center, we have some YouTube videos that we've set up for you. You could watch them and use them in your practice. In India, many people have gone to black dye after seeing my videos. It's very cheap. You can procure it in Sri Lanka as well, I hope. So you only have to inject 0.2 to 0.3 ml in the node that you've biopsied. Inject in the cortex, don't inject in the tract or around the node. And the injection can be done at the time of biopsy or at a separate visit. So for the NodeSmart study, this is what we've set up. So patients with T1, T2 tumors with up to 2 abnormal nodes, they have a sentinel lymph node biopsy and removal of the marked node. The surgeon has to take at least 3 nodes out. And the reason for taking 3 nodes out is to help you assess the tumor burden. Because if 3 out of 3 are positive, then you would go back and clear the axilla. But if only 1 or 2 are positive, then you can give radiotherapy to the axilla instead, based on AMROS study, till post-hoc reports. And if once post-hoc reports later this year, if it shows you don't need any further X-ray treatment, then you don't need to do anything else in these patients. And how do you mark the node? Marking is as per the ATMAC trial protocol that you can access online. So you use a Devil tracer technique to do your sentinel lymph node biopsy, preferably. You can mark the node using any technique and take at least 3 nodes out, like I mentioned previously. You don't have to mark every abnormal node, but if your radiologist or your MDT is uncomfortable, so for example, if on ultrasound scan you see 2 abnormal nodes, and if you feel uncomfortable, just to reassure yourself, you can mark both nodes, and the surgeon may feel more reassured in removing both the nodes. But you don't need to do that because you'll be removing at least 3 nodes anyway. So this is where we stand with upfront targeted X-ray dissection. I think the terminology is a bit confusing because it has X-ray dissection in it that causes confusion, even at my center. I think a simpler technology that I would recommend is targeted sentinel lymph node biopsy rather than a targeted X-ray dissection. And it's much more simpler than doing a targeted X-ray dissection after neoadjuvant chemotherapy, because you're not facing the problem of shrinkage of the node and the clip migrating from the node because of neoadjuvant chemotherapy. So it's much more simpler technique. And you don't require any special training because surgeons who are used to doing sentinel lymph node biopsy and taking nodes out, so it's a very similar technique. So just to summarize, so this is the treatment flow chart that we follow in the UK. It's just been finalized. I have written this section for the UK ABS guidelines. They will be presented in June this year at the ABS meeting in Glasgow. So this is just summarizing what we've just discussed so far. So if you have micrometastasis, no further axillary treatment. If you look at my cursor here, if you have macrometastasis, then you can give radiotherapy to the axilla. And if you're convinced with Z11 for a very small tumor like T1 grade 1-2 tumor, then you may not offer further axillary treatment, but it's very reasonable to offer radiotherapy while you're waiting for post-hoc trial results if you don't believe in Z11. In all of the cases, you do axillary treatment, and radiotherapy is preferred based on AMOROS. Obviously, if the tumor burden is more, for example, here, if you look at my cursor, if 3 or more macrometastasis or large tumors like T3, you proceed to lymph node clearance. So these are on this right-hand side of the slide. If you have radiologically positive disease, like I summarized, T1, T2 tumors with 1 or 2 abnormal nodes on ultrasound scan, there is no need to jump to a lymph node clearance. You can do TAD or targeted sentinel lymph node biopsy, and patients can be entered into the national Node Smart study that I mentioned. If they have 3 or more macrometastases, you do a lymph node clearance. Otherwise, you can just give them radiotherapy till post-hoc reports. And once post-hoc shows, if it shows that you don't need any further treatment for these patients, then you don't need to do any further treatment. Because just because you found disease on ultrasound scan shouldn't change how you treat these patients, because the final gold standard is what you find on histology. So last couple of slides is just to take you through the post-neoadjuvant setting, because it's I think combining both is a long talk. So I'll just include a couple of slides for that, just to give you a flavor of what's happening in the post-neoadjuvant setting for patients who are node positive to start with. So patients who are node positive to start with have neoadjuvant chemotherapy. Then in many centers, they come back and have a lymph node clearance. But we know that the response rate in the lymph nodes, if you look at my cursor here, depending on if they're HER2 positive or triple negative, it can be up to 50% or more. So the question is that these patients who have a complete nodal response, do we still need to do a lymph node clearance? Or can they just have what we discussed, like a targeted axillary dissection or targeted sentinel lymph node biopsy? Now, there was an American study published recently called the B51. So in that study, what they did was patients who were node positive to start with had neoadjuvant chemotherapy, and then they were randomized to either no radiation or regional radiation if they had no residual nodal disease. And what they found is that there was no difference. So that study potentially showed that if you have a complete nodal response, you don't need to do anything to the axilla. But the problem with this study is that if you look at the red box I've highlighted, the same problem that was with the Senomax study, half the patients had a lymph node clearance anyway. So they were lymph node positive to start with, right? Then they had neoadjuvant chemotherapy. Then they had lymph node clearance. And then they were randomized to radiotherapy or no radiotherapy to the axilla. That doesn't make sense. Because if you've done a lymph node clearance anyway, why would you randomize to radiotherapy or no radiotherapy to the axilla? Because I wouldn't give radiotherapy to the axilla anyway. And that's the problem with this study. So you can't take the results on how they, I would say, advertise the results. And this is not brought out in the paper, I'm afraid. So that's the reason you can't believe this study, that half the sample size had a lymph node clearance anyway. So that doesn't give much confidence in the study. So the ACNEC study that I'm doing in the UK, and it's in Ireland and other countries as well. So it's again a confirmatory study. So where patients who are node positive to start with have neoadjuvant chemotherapy, then they have sentinel lymph node biopsy or targeted sentinel lymph node biopsy. And if there's no disease, they're randomized to radiotherapy or axillary treatment or no axillary treatment. They don't have a clearance. So this study, we already have around 800 patients randomized. We have more than 90 centers in the UK, and we will have the results in a couple of years' time. So till then, this is my last slide, just to summarize how I think the post-neoadjuvant chemotherapy treatment decision for node-positive patients. So sentinel lymph node biopsy and remove the marked node after neoadjuvant chemotherapy. If you have no disease, then still we need to give radiotherapy to the axilla or randomize an ATNAC trial in the UK, where patients will be randomized to no radiotherapy or radiotherapy. If you have residual disease, if you have isolated tumor cells, again, I think based on some non-randomized studies published or presented recently, you can consider radiotherapy rather than jumping to a clearance. But otherwise, for micro and macro metastasis, post-neoadjuvant chemotherapy, because this is chemo-resistant disease, you would still consider lymph node dissection. Thank you very much. Thanks, Theekshana. So these are just some final thoughts that I've summarized in the conclusion slide. Just to say that, I think more data is accumulating. So we'll see a change in axillary management in the coming years. But I think we've got so far. I would be happy to take any questions. I'll stop sharing my screen.
Thank you very much, Mr. Goyal. I think that's an excellent presentation, plus an excellent start for this webinar series. I'll just go through a few questions. One of our listeners have asked if a surgeon has removed only 2 nodes with sentinel node biopsy, and if those 2 nodes are positive, doesn't say whether it's macro or micro or ITC. If the tumor is T1, T2, what is the option? I think you've covered it, but just to answer this question.
Yeah, I think the question you probably want to ask here is, which I often get, is that if 2 out of 2 are positive and the surgeon has only taken 2, how do you know that if the surgeon had taken third one out as well, or a sample? The one thing I think you have to be clear is that, which doesn't get discussed much, is do most patients have 3 sentinel lymph nodes? The answer is no. So if you look at all the trials that we publish, Almanac, New Start, the median number of sentinel lymph nodes is around 2.2, 2.3. So most patients won't have 3 sentinel lymph nodes. So if you're taking at least 3 nodes out, like I mentioned, for node smart, for upfront TAD or upfront targeted sentinel lymph node biopsy or post-neoadjuvant chemotherapy, the third node is most likely the one that you go to old-fashioned sampling. So you're going by feel and taking the third or the fourth node out. So 2 out of 2, I think the concern in your mind probably is that I've only taken 2 out, both are positive. Now, how do I know that the third one was positive or not? Because I've never taken it out. So, but based on the data at the moment, combining the AMROS and the CENOMAX study, you could consider that T1, T2 tumor with 2 macrometastases, you can consider radiotherapy to the axilla if you wish. But just to give you a practical scenario here, I myself had a patient yesterday in the MDT. So this patient had, I think it was only 1 abnormal node on ultrasound scan, had a core biopsy positive disease, but had I think T2 tumor. So we did a targeted sentinel lymph node biopsy. We didn't jump to a clearance in this patient. The histology, when we discussed it yesterday, came back as 2 out of 4 nodes positive, right? But both of these 2 nodes had extranodal invasion. So the question in our MDT we discussed is that actually both nodes have extranodal invasion. And the tumor, instead of being T2 now, on histology, it was 6 centimeters, unfortunately. So it became a T3. So what would we do? Now, do we apply the CENOMAC and AMROS results and just give or offer radiotherapy to the axilla, or at least discuss it? Or do we go back and do a clearance? So on balance, we decided as a MDT that we go back and do a clearance, because now the burden of disease I'm looking at here is both nodes have extranodal invasion, and plus it's a 6 centimeters tumor. So then we decided, no, I think we wouldn't be discussing radiotherapy to the axilla. We'll do a clearance. So I hope that helps you, that it's not black and white, but consider it as a whole, I think. So if these nodes have extranodal invasion, then you may be, or your oncologist may be a bit reluctant to offer radiotherapy to the axilla. But if there's no extranodal invasion, maybe, and it's a T1, T2 tumor, then you can consider radiotherapy to the axilla based on Amaros and Senovac.
Thank you very much for that. This is a question that, I mean, in our setup, there are different guidelines in play in our setup. So this is probably why this question is coming up. If pre-neoadjuvant, a patient has a negative axilla, what is the axillary management post-neoadjuvant?
Yeah, so in our setting in the UK, if the patient is node negative at the very start, so if you're doing an ultrasound in Sri Lanka for axilla before they start neoadjuvant chemotherapy, then in the UK, we would recommend just doing a pure sentinel lymph node biopsy. Is that what you do there? Or is that something else you recommend?
No, in our setup, we go for neoadjuvant and then do a sentinel lymph node biopsy. It was
Yeah, so that's fine. Then. So
yes.
that's consistent then.
Yes.
So you do a sentinel lymph node biopsy. Yeah.
There was in different schools of thought at one point where people considered doing pre-neoadjuvant sentinel nodes, but
yeah,
but mostly
I
now
agree.
We are consistent.
So we used to do that in the UK as well. So till a few years ago, I think the pre-neoadjuvant sentinel lymph node biopsy, still some centers would consider that, and but now no center does that. Yeah, they've moved away from that.
If I may ask now, we do have an issue with tracers. We don't have the dual tracer most of the time, like 90%, 95% of the time we use just the blue dye, and it's not the patent we use.
That's fine. I'm quite used to this because I travel a lot, and so I think that means Sri Lanka is not very different from India then.
Yes.
Because I was visiting AIMS New Delhi a few weeks ago, and so I learned the same thing, that in India as well, they hardly have radioisotope in any of the centers, and they mostly use blue dye, and patent blue is very costly, so India doesn't have it. So what blue dye do you use here?
Methylene blue.
Yeah, so that's what India uses as well. And I think some of the side effects that have been quoted in the literature, like fat necrosis, or they are there, but I think on balance, I think methylene blue works very well. The other thing I don't know if you have access to is, I know in India they have moved to ICG as well at some centers. So I don't know if Sri Lanka has a very similar landscape. Do you have ICG?
We do have ICG, but still that would need a bit of more equipment and expertise. So therefore, I think we are on the side of a single tracer at this point in time.
So you could use a single tracer. Then if you're setting up targeted sentinel lymph node biopsy, what you could do is you could combine that with a black dye, which would be very cheap in Sri Lanka. And you could ask your endoscopy, people who do endoscopy and mark the polyps, what dye they use to mark the polyps. And my guess is they'll be using the black dye. Yeah. So that's how when I did the first study to optimize or set up the protocol for black dye node marking, I went to our endoscopy suite here at Derby. I checked what they used, and I then contacted that particular company that, can you actually load this? They used to load it in 5 ml syringes. So I negotiated with the company to make a 1 ml syringe to load a pre-filled syringe. And they did that in the UK.
Another question. If you do not find a sentinel node biopsy, we rarely come across this situation where you can't find the sentinel node biopsy, especially with single technique. What is your step in the UK? What would you do?
Yeah, so we do 4-node sampling. I don't know if that is recognized in Sri Lanka. So it's 4-node sampling is basically, just to put it in a very simple or plain language, is you go by feel. And so you palpate and look for 4 nodes. and you take them out. So we don't jump to a clearance. And the other thing you could do is, rather than jumping to a full-fledged clearance, if you're not comfortable with 4-node sampling, you could maybe just do like a level 1 clearance rather than doing a full-fledged clearance. Hopefully that will save some essential lymph nodes for the patient and decrease the risk of lymphedema and arm morbidity.
Thank you very much. Why I asked it, I myself practice the 4-node sampling since I've been in the UK. Why don't we now, for example, when we are using the single tracer, we often come across either 1 or 2 nodes.
Right.
So why don't we really practice? I come up with this question: why don't we really practice the 4-node sampling sort of as a completion, feel for at least 2 more nodes and complete the 4-node sampling?
That's it. Yeah, that makes sense. And if you look at, I published around 3 papers now for this, for Almanac trial, and then the New Start training program, where I showed is that the false negative rate, even for sentinel lymph node biopsy, if you take only 1 out or 2 out, it is still more, but it only drops down significantly if you take at least 3 or 4 nodes out, even for sentinel lymph node biopsy. So if you take that additional, if you're doing a single tracer, and if you take at least 3 nodes out, and the 3rd node could be, like you said, by feel, traditional 4-node sampling, that will help you to decrease your false negative rate. And especially in a low resource setting like India or Sri Lanka, I think it's a very good technique. You don't need any costly stuff, and you can still save the patient the arm morbidity for a lymph node clearance. So you could call it like a blue dye guided sampling.
Yeah, yes. One of my surgical oncology colleagues, Dr. Anuj Kumar Singh, asked a question: a 60-year-old female T2 ER positive, HER2 positive cancer with negative axilla, underwent neoadjuvant chemo, and then had a mastectomy with sentinel node biopsy. Pathology shows complete PAT-CR with fibrotic changes in 2 out of 4 sentinel node biopsy due to possibly due to systemic. What do you recommend the management for? It's a complete response.
So we include these patients in the ATNAC trial. So in the ATNAC trial, the patients can be proven node positive to start with on FNA or core biopsy, or patient like this. So this patient would still be considered node positive at presentation, just that we didn't detect it, that's all. So it's no different. So this patient is this, she was node positive at the very start, because you've already seen downstaging of fibrotic changes in 2 nodes. So she would be randomized, if she was in the trial, to axillary treatment or no axillary treatment. Outside a trial, she will have radiotherapy to the axilla.
Hopefully that answers the question. One important thing that is that in our setup, sometimes if a radiologist sees an ultrasound scan, in the ultrasound scan sees an abnormal lymph node in the axilla, they just mention there's an abnormal lymph node, but they might not quantify the amount of lymph nodes, might not look into the cortical thickness. Most of them do. What is your standard your radiologists usually take up? Do they quantify all the time if it's 1 or 2?
No. So they will only say, so if you look at the reporting here in the UK, unfortunately, it's not as standardized. So the definition of an abnormal node will differ from center to center. So for example, Darby and Burton, the cortical thickness our radiologists use could be 2.5 or, so that would differ from a center in Leeds. So there is no standardization or any guidelines at the moment. So based on published evidence, I think the radiologists decide their own, or the unit decides their own cutoff of what they think is abnormal and what should trigger a FNA or a core biopsy. And at the moment, in the report, they won't mention in the symptomatic sheet that, the cortical thickness was this. They will just say, okay, 2 abnormal nodes or 3 abnormal nodes. They won't mention that, I'm afraid. So that's something which in the future, hopefully there'll be some standardization. But my guess is, with more and more of being less reliant, like we are doing upfront TAD now, like for NodeSmart, where even if there's only 1 or 2 abnormal, and Americans don't do axillary ultrasound scan. So I think there'll be less and less reliance on ultrasound scan, I think. Apart from telling us the extent of the disease, that is that just one abnormal node or maybe two or more than two?
Very last few questions, Mr. Goyal. I will let you go in a bit. Another colleague of mine, Dr. Heshan Sirivardhan, is asking, we frequently encounter patients who have undergone lumpectomy without adequate, proper pre-evaluation workup. And the lesion is subsequently found to be malignant, which is common in our setup, to be frank.
Yeah, it's common in India as well.
Yeah, as well.
Because
Yeah.
I get the same question I got asked there. And
in
they
such
find
cases,
that,
just a question, in such cases, particularly when the tumor is located in the upper outer quadrant, how should the axilla be evaluated?
Yeah, so we know from the studies, I think, that the sentinel lymph node biopsy after excision biopsy is inaccurate. There's more chance of false negative rate, and we know that, and it makes sense because your lymphatics are disrupted, like you said, if you're especially doing an excision biopsy in the upper outer quadrant. So you can still try sentinel lymph node biopsy, inject the blue dye, and my only suggestion would be don't inject it. So if your scar is in the upper outer quadrant, just inject it, like towards the axilla rather than, or inject it in the periareolar plexus, so that, don't inject it. So just go a bit towards the axilla on the scar. So I would say superior and lateral to the scar.
Would you do that to a tumor that is encompassing the outer quadrant, sort of might be blocking?
Yeah.
It's a familiar face for me. Would you do that to a bulky tumor that is sort of possibly blocking the lymphatics? We sometimes see the sentinel node is not picked up, especially with the blue dye, when that happens.
Yeah, it won't happen. Yeah, so be prepared that the technique won't work. So you want to do your old-fashioned. Still, don't jump. The two things you want to do is, one is, if you can get an ultrasound of the axilla before you proceed to surgery. Because if your ultrasound to the axilla with FNA or a core biopsy shows malignant nodes, so you have some kind of a staging before you jump to surgery. So let's assume that your ultrasound, you've done an axillary ultrasound, and you're not concerned about the axilla, then do a blue dye guided sampling. So even if the blue dye doesn't work, do a traditional 4-node sampling. And most likely, like you said, it won't work. So you'll have to resort to 4-node sampling, I'm afraid.
Thank you very much. Last question, Mr. Goyal. A bit about the sound trial. Now they're trying to get away from, touching the axilla, de-escalating the de-escalation rather. Just a word on that.
Yeah. So if you look at the sound trial in the UK, we've included that in the guidelines, along with the other trial, which was the NCEMA trial that was published recently. So in the UK, they're being very cautious for these two trials. So the interpretation in the UK is that probably in an elderly patient or a postmenopausal patient with a T1 tumor and no other risk factors, you could still consider omitting sentinel lymph node biopsy, but not in a very so the results are not generalizable to the inclusion criteria of the studies. So they're being very cautious. And in the UK, the guidelines that will come out in June, they will almost be a bit more conservative compared to the American guidelines. So the ASCO
Mr. Goyal? I think we momentarily lost connection. We've come to the end of the presentation as well as the discussion. Thank you for all of you who've joined. It was a pleasure. And Mr. Goyal, I think, did a really good presentation and well descriptive. Unfortunately, we couldn't, thank him in person. But I would like to thank Mr. Goyal for his time, as well as taking some of the questions. And I would ask all my colleagues and junior colleagues, as well as colleagues from out of Sri Lanka who've joined in, to keep connected to us as well, and we'll keep doing further webinars and educational activities. Thank you very much.